of Strategy and Partnership Division of Palliative India. Her work focuses on ensuring safe access to opioid analgesics for pain relief in India by engaging with several government and other key stakeholders. She is a liaison officer between Palliative India's flagship clinical program and the WHO Southeast Asian Regional Office for Essential Drugs and Medicine. She leads the capacity bridging programs for Palliative India through partnership and other social development sector actors. She has been the spokesperson for civil society perspective for LMICs on various platforms, including events hosted by Vienna NGO Committee and UNODC. She works for the improved death literacy, appropriate end-of-life care, and for the inclusion of people with lived experience at decision-making fora. She is an India advocacy focal point for the International Association of Hospice and Palliative Care and is a board member of International Drug Policy Consortium. Trained as a psychologist, Smriti began working in palliative care in 2001 after the loss of several family members in quick succession. This is just a very brief about what Smriti is all about. You will learn about her more. And this is one faculty you're going to see for many sessions from now. Thank you so much, ma'am, for being with us. And it's over to you. Ma'am, you're muted.
Thank you. Is my audio all right?
Yes, ma'am, it is.
Okay. I have to warn you that I have a lot of background noise that could be happening, including some farm animals. So if you hear that in between, please ignore it. Also, Raju, if my internet is patchy, I will switch connections over and rejoin. Okay, hi. So my name is Smriti, and it's great to see a full room. I think there are still people logging in. But while we wait for everybody to come, I will just give you a little bit more of a background into this particular foundation course for palliative care class. It was really a labor of love because, especially for people who are not medical professionals, there were lots of courses that were available to doctors and nurses, but nothing for people like me who did not have a medical background but wanted to get involved. So a bunch of us got together and put this together. It reflects what we feel are the needs of the sector in terms of psychosocial care. So you'll see that in the weeks to come that you're with us, we're covering a vast range of topics. And I have to also tell you that we are going to be skimming the surface with a lot of the topics because it's an introduction to palliative care in many ways. And of course, if those of you who are who would like to have deeper conversations about any of these particular topics, I also want to say that you can get in touch with any of us at any time, and we're happy to have that conversation with you. Just a few housekeeping rules. I know the other faculty also prefer it, but usually on my classes, I pretty much insist on cameras being on for the simple reason that it improves just the human interaction and the fact that we're all little Zoom fatigued over the last few years. I wish we were all sitting together in the same room, but since we're not able to do that, at the very least, at least when we stop sharing slides, when we have these interactive discussions, I will request that your cameras be kept on. I know some of you might have bandwidth issues, which then in that case, it's perfectly fine. But if your bandwidth is allowing it, it's perfectly okay. And don't worry if you're relaxed in a chair or if you don't feel like you're at your professional best looking, it's fine. You'll find that over the next few weeks, we'll get to know each other a lot better. Okay, so I noticed Raju and Senia had sent me a list of the participants, and I have to say that I was really, I had mixed emotions about it because on one hand, I was really pleased because it's a very diverse and mixed group. I'm really happy to see people from all walks of life joining in. Also, I was a little bit intimidated by the fact that I'm also facing a very experienced group here. So what I will also encourage all of you to do is to please use the chat box to ask questions, to leave reflections, to comment, even anything that you might want the rest of the group to know, some article, a link to an article that you've read. So please use the chat box as a means of communicating with the large audience as we go along. I will request one thing though. in our experience with palliative care, it tends to trigger certain personal and powerful emotions. And I encourage you to share them. Please share your, the stories, your experiences as they come up for you. But if they are very personal experiences, I will request that you save the sharing of it to the very end, once we're done with the academic part of the sessions, because then we'd really like to be able to spend time with people who are sharing these experiences and not saying, okay, we're running short of time, so we're going to have to move forward. So we encourage you to share, but please try and keep personal shares towards the end of the session. Okay, Raju, and also if anyone would like to say something, I will stop from time to time, stop sharing screen, and I will come back to the room. And in that time, you're welcome to unmute yourselves and speak or put a hand up, and one of our facilitators will help us cue you so that we can listen to what you have to say. Okay, very quickly now, just by means of, we're not going to have the time to really get to know all of us individually. I'm going to ask you to do one thing for me before we start, and that is to put in a check-in word. And what I mean by check-in word is how in this moment right now you are feeling. And don't think about it. Don't think about it too much. Even if you're tired, even if it's a negative word, it's fine. Are you sleepy? Are you hungry? Are you tired? I like that the first word I read was excited. That's encouraging. Okay. Some of you might be juggling different things. They have other things going on. It's just good for us to know where all of you are in this moment. Yeah. Hungry. Okay. I don't know if hungry is a better way to be here, because if you're full, then you might take a nap. So stay hungry for a little while longer. We'll take, oh my God, everything is physiological and food-based almost. Okay, great. So fine. I think we're going to have to take a break 45 minutes from now. Raju, please cue me so that people can go and get themselves a cup of tea. All right. Cool. Let's get started. Okay, so how many of you here, you can, I hope all of you know how to use the reactions button, the bottom of your screen, if you want to put your hand up, or, when I ask you to share an emoji sometimes, just to get a sense of what's happening in the room. Anup had his hand up. Did you have anything to say, Anup? No? Can't hear you.
No, I was just checking my emojis. Sorry.
All right. Okay, great. Super. Okay. So how many people in this room have got experience with palliative care? Raju and Srini, I can't see all screens at once. So
three hands up till now.
Okay. All right. Senior, also, I'm going to very quickly ask you, do you have access to my last introduction to palliative care
Yes, I have.
slide deck?
Yes, I have.
Okay, so I'm going to ask you to share, please, because I'm having some trouble with my. All right. Okay, so I can see that the vast majority have, well, not a lot of experience with palliative care, but some. All right, that's okay. I will also, okay, that's great. Fantastic. Okay, so you've all heard lots of different things about palliative care. A lot of people associate palliative care with terminal care for cancer patients, end-of-life care, pain relief. These are the four largely most common things that we hear about palliative care. I'm here to tell you, first of all, that's not true. Palliative care is not just for people with cancer. It is not just for end-of-life care. It is not just pain relief. Great, there are some people who are actually working in palliative care departments. That's great. So I will also lean on people like Swizzle and Femita, people who've had experience also from time to time, to elucidate on your experiences that you've had in your settings. Okay, so let's get started. Senior, do you have the slide deck ready?
Yes, ma'am, we have, but we have the PDF file.
That's
I think it works. Good, ma'am. We will share it right now.
Thank you. Yeah. So yes, please, first slide. You can go to the next one. Yeah. Okay. So first, no, sorry, this one. Yeah. So before we talk about palliative care, it is really important for us to talk about healthcare. And why is that? Because what we're trying to do is to integrate palliative care into the larger healthcare system. And we can't do that if we don't understand, somewhat in the same way what healthcare means, especially in the current situation and scenario in our country. So according to WHO, health is not only the absence of disease and infirmity, it is also the presence of physical, social, and mental well-being. I'm going to read that one more time. Health is not only the absence of disease and infirmity, it is physical, social, and mental well-being. You can stop sharing this, Senior. So I'm going to ask you a question. In this definition that you have just read, do you think what we are experiencing today as a society is healthcare, good healthcare? Not just the absence of disease and infirmity, but also the presence of mental, physical, emotional well-being. Do you think we are looking into the well-being, or are we looking at only disease and treating it?
Obviously for well-being.
Sorry, Anukriti, say it again.
Obviously for well-being.
Okay. So, Sina, you can also, maybe what you can do is also you can email me the PDF so I can also try and control it from here. Okay, just email it to me, but for now we can share the screen from your side. Okay. Yeah, so next slide, please. I see that a lot of people have said that the focus is mostly on the physical part. Sorry.
Just a second, ma'am.
No worries. Sorry about the technical glitches. But I hear it's actually auspicious if you have it in your first session. So then the rest of your session goes pretty fine. All right. So yeah, the focus is mostly on the physical and social. Now, India's healthcare, as of this this quality health access and quality index, was considered amongst one of the most unsatisfactory in the world, where at the time in 2015, we had ranked 145th amongst 195 countries, and we were behind our neighbors like China, Bangladesh, Sri Lanka, Bhutan, etc. COVID didn't really help us much, and I don't know what the latest figures are. I have to look that up, but I don't think we have made a lot of progress. Maybe states within the country have improved access and quality care on their indices separately, but we as a country as a whole have not made a lot of progress. Next slide, please. Okay, so why am I showing you a slide about the National Crime Records Bureau? Because according to the National Crime Records Bureau of India, in 2014, 26,426 people in India suffering from various ailments and NCDs like cancer, AIDS, paralysis, etc., chose to end their lives. This is the suicide statistic in India. And as of 2021, which is the latest slide, which I haven't replaced here, we are still at 18% of the number of suicides that take place in the country. 18%. I want you to think about that. So that's approximately like 1/5 of the number of people who choose to end their lives, choose to do so because they're living with a life-limiting condition. Now, there is no study to corroborate the two, okay? I'm just saying, but if you apply your mind a little bit, Senior, can you stop sharing? I just want to check with the group. Why do you think that so many people living with NCDs and with various life-limiting, life-threatening conditions, why is it that they're choosing to end their lives? What could possibly be the reason? Please use the chat box. Please unmute.
Lack of support, lack of hope.
Lack of support, lack of hope. Access.
Ma'am, I think it is all around the socioeconomic condition, we must say, rather than the support. Support is very important, but the socioeconomic status, if the treatment is very much costly, definitely they cannot go forward. So socioeconomic factors, biopsychosocial factors, definitely.
You're absolutely right, Anne. And I also see that you said that our healthcare is improving. So I agree with you to some extent. Okay, depression, lack of support, pain, hopelessness, depleting resources, lack of mental health awareness, financial distress. I think we're getting the gist of why this is happening, right? So we can see why somebody who's living with a chronic or advanced or serious illness would want to choose to end their lives rather than be a financial burden or just the amount of suffering and pain that people are experiencing. So Sina, yes, please start sharing again. Okay, so this was a quote by Dr. Sankamitra, who is one of he's a doctor who was on our board many years ago, and he runs he's one of the founding members of the Eastern India Palliative Care Services also. And he said this very interesting thing. He said the poor die in misery and neglect, the middle class die in misery of ignorance, and the rich die in misery on ventilators, and no one gets a pain-free and dignified death. This was an observation that he made many years ago. And next slide, please. The quality of death index was something that was published it's published every 5 years. The latest one came out in 2021. And the quality of death index is basically an economist intelligence unit study that is commissioned by the Lien Foundation in Singapore. And this study, we can share it with you. It studies the quality of death based on various parameters like access to medicine, healthcare, infrastructure, training of teams, communication skills in the healthcare system, and so on and so forth. And India ranked in 2015, 67 out of 80 countries that were studied. In 2021, we moved up a little bit to 59. Yeah, we'll share all of these, Narayanan, as learning material PDF files. Yes. Okay. And so please go back. We were 67, now we are 59. And what does this really say? Also, please go back. I want the class to also please take note of the fact that all the countries on the top are first world countries. All the countries in the second half are mostly low and middle income countries. Okay, that's just for you to note for a bit, because I will be coming back to the point of the differences between low and middle income countries and high income countries several times over the course of this entire series, not just in this class. Yeah, next slide, please. Now, like some of you said, one of the reasons why someone might choose to end their lives is because of the financial distress that the family goes through, the financial toxicity. And there is actually evidence to show it, that in this was published in the Lancet in 2018, but was a study that was published in 2017. Catastrophic out-of-pocket healthcare expenditure pushes 55 million Indians below the poverty line every year. 55 million Indians every year are pushed below the poverty line because of how much we have to spend on healthcare out of our own pockets, out of which 38 million people are pushed below the poverty line because of the cost of medicine. Next slide, please. So the reason I'm also saying this to you is I'm tying it back to, it's easy for us to work in our little silos wherever we are, but we need to understand that a lot of the policies, a lot of the ecosystem that we work within are also connected to larger discussions and larger policies being made elsewhere. And Astana is a place in Kazakhstan where actually we all know about the universal health coverage phenomenon. And this was actually where it was really sort of declared in Astana in 2018, where countries around the world got together and said, this is what universal healthcare means, and this is what we need to aspire to give everybody. Quality healthcare should reach people where they are, when they need it, at an affordable cost. I've highlighted some words in certain colors. Quality. It has to be of good quality. It can't be of low, substandard, suboptimal quality. It has to reach people where they are, when they need it. So that is in a timely fashion and in a place where they need it most, and at an affordable cost. Okay, and health for all has to be health with all, and people have to be included in designing and controlling health systems. You cannot have medical care that is inflicted upon you. Medicine is not something that is done to people. It is done with people, for them. And so the Astana Declaration really sort of takes that into consideration. And this is what we said. Now, it sounds really great, doesn't it? quality healthcare reaching everyone when they need it, where they need it, at an affordable rate. But we are not anywhere close to it. It seems very utopian at this point, but at least it gives us a goal to work towards. So this also gives us a sense of where we are right now. And if 55 million Indians are falling below the poverty line every year, something is very wrong. Okay, next slide, please. So I want to also share the story with you. This is something we experienced. This was in 2016. The story came out, and some of you might be familiar with it, where this gentleman there, he had approached a court in Andhra Pradesh, asking for permission to euthanize his son. And his son was a 4-year-old, and he had cancer, and he was in extreme pain, and the parents couldn't bear to watch it anymore. So, of course, the petition was denied. But the story broke, and a lot of us from different palliative care organizations around South India heard about it, and we wanted to track this gentleman and his family down. And so, there's this huge, large-scale search that happened, and eventually we found the family in a hospital in Bangalore. And the thing about this family was that they had been to every major city in South India. They'd been to Chennai, they'd been to Coimbatore, they had been to Hyderabad. And in Hyderabad, ironically, they had been in a hospital that was a stone's throw away from one of the best pediatric palliative care centers in the country. And there was no referral done. So what had happened is that a social worker got on a bus, overnight bus from Hyderabad, with a prescription of morphine prescribed by a pediatric palliative care doctor. She went across to Bangalore trying to reach this boy and was denied access to him. And this boy basically died in excruciating pain a few days before his 5th birthday. And I wish this story was an anomaly, but it's not. And we know of another story in Kerala where in a hospital, parents actually, they killed their son and then jumped out of the hospital window and ended their own lives. And what kind of pain pushes people into these horrific scenarios? Some of you are witness to that pain because you've either been caregivers or you actually work in settings where you know how bad this pain can be and what denial of pain relief can mean to families like that. Next slide, please. So now, what is palliative care? And why did I tell you this whole Mahakatha before I got to this point? The reason palliative care is important is because we're looking into various dimensions of the kind of suffering I just shared with you. Palliative care is not just pain relief. It is also addressing financial toxicity. It also, in its true form, palliative care seeks to mitigate serious health-related suffering. I want you to know this phrase if you are not already familiar with it. Serious health-related suffering is a phrase that the Lancet Commission for Pain Relief and Palliative Care came up with. And if you really break it down, serious health-related suffering, it talks about any suffering that is brought about by issues of illness and disease. Now, in our country, or in several countries across the world, the disease of one person has the power to disrupt and derail the entire family in every way. There is emotional stress and distress and pain as well. But also, the disease of one person in one generation can cause multi-generational impact on the economic health of the family. It can cause people sell their homes, they mortgage their houses, people's education comes to a stop just so that they can pay for treatment costs. And at the end of it all, when curative treatments fail, palliative care is not sought out as much, and less than 4% of our country has access to palliative care. And at the end of it, people die in excruciating pain and agony or lack of symptom control. So next slides, please, Senior. Now, firstly, I'm going to just take you through very quickly some of the most pervasive ideas that people have about palliative care. I already touched upon it in the beginning, but I'm going to take you through these. Actually, what I'm going to do is I'm going to ask somebody from the class to read it out. Because, can we have a volunteer?
Anyone wishes to volunteer can unmute from their end and speak. Yes, Narayan. Please go ahead.
Let's take it from the myth and the reality. Please go ahead.
Narayan, sir, you can unmute from your end and speak.
Yeah, am I audible now?
Yes, perfect.
Yeah. So the myth is palliative care is only for people dying of cancer. The reality is palliative care can benefit patients and their families. Just a moment, I need to minimize this. Yeah. Yeah. Palliative care, the reality is that palliative care can benefit patients and their families from the time of diagnosis of any life-limiting or life-threatening illness, not necessarily end of dying only. Can I move on to the next one?
Yes, sir, yes.
Yeah. So next myth is that palliative care means giving up and there is no hope for me. In reality, hope becomes less about futile interventions and cure and more about living a life of quality as fully as possible. The other myth is palliative care hastens death. In reality, palliative care does not hasten death. It provides comfort and best quality of life from diagnosis of an advanced illness until the end of life. So actually, yeah, I think it means you improve your living span and does not actually hasten death. The other myth is pain is a part of serious illness and dying, but it doesn't have to be. Pain doesn't have to be a part of illness and dying. There are many ways it can be alleviated. Morphine is administered to hasten death is a myth. The reality is appropriate doses of morphine keep patients comfortable, but do not hasten death. Another myth is taking pain medications in palliative care leads to addiction, but in reality, appropriate doses of morphine and other opiates used with training and understanding do not lead to addiction. Is that?
Thank you, sir. Smriti ma'am, you're muted.
Yeah, thank you very much. Thanks a lot. So, Senior, you can stop sharing. I've actually downloaded the thing, and I'll just make life easier for you also, I think, if I control the slides. Okay, so did anything surprise any of you? Any of these myths, any of these realities surprise any of you? Yes, Mr. Narayanan?
All of it. Every one of those myths was still a myth. Till I read it, it was a reality for me.
Thank you. I'm glad that has changed today. Anybody else? Did anything come as a surprise? Yes, Geeta, do you want to tell me a little bit more about what your idea was about hastening death? I'm interested to know, because that's
actually, ma'am, I was not feeling that palliative care hastens death. So I was thinking, why would people think like that? That's what I was wondering. I've never thought of it as hastening death, at least not when I was taking care of my father, who was in the last stages of cancer. So I just wanted him to be as long as possible alive. I never wanted it that he should leave us.
Thank you, Geeta, for sharing that, and also that very personal story. But your question was, why would people think that? Why would people think palliative care hastens death? Can someone tell me? Why would anyone think that palliative care hastens death? Yes, Narayanan.
Yeah, I think basically because active medication is stopped, right? So we think that it is equivalent to let death happen in its due course, and it may happen soon because active medication is not being done. That's my guess. Yeah.
You're absolutely right. And I think part of that is that people believe that palliative care can only come in after you stop curative treatment. So it is a last resort. And basically what it's doing is it's not really doing anything to prolong life, and therefore it is hastening death. A lot of people also believe that morphine as a medicine hastens death.
Okay.
Yeah. Neha, you say it can also be an association. An association with what?
Like soon after, for instance, it can be that, once we stop active treatment, I mean, very close to what Narayan sir had said. So very close to that. But if you see, once we stop active treatment, sooner or later, once this comes in, it's an association that they might have, that this can be caused by, because we palliated the patient and all that. That's what I meant.
No, you're absolutely right. It's by association also. Okay, great. So any other myths that have been busted for people today in a big way?
Ma'am, I think most of the families don't even think about the chances of getting recovery, rather than just putting them in the palliative care center. So once taking my example as a volunteer in a care center, we had a lot of patients, and the after effect of our intensive care is like we were able to restore them to the family life. So they were quite amazed. Oh, is that possible? So we said, yes, of course it is possible. That's why your grandfather is here to restore in your family. So they all think that there is a kind of taboo, like always we have in our society. So it is possible to restore them to the family life, of course.
So that is a great point, Anne, because what you've just mentioned is a reframing of hope. A lot of people say that don't talk to my parents or my family or my loved one about palliative care because it will take away their hope. And when you ask them, what is that hope? How many people in this room, it's a very serious question, please don't take it please don't take it lightly. How many people in this room think we will live forever? No? Come on. Really? This is so shocking. Because when we talk to a lot of family members, they say, it'll take away hope. For what? For life. Like Dr. Raj says, the inevitable consequence of being born is to die. We're all going to die someday. And the thing is that what is this hope that we're worried about that will be taken away? So what Anne just actually demonstrated to us was that you can actually restore hope in another way and say, okay, you know what? We can help you live a life where you can interact more with your family. We can help you, not be in pain so much. I mean, those are also very hopeful aspirations to have. And there is evidence to show from different parts of the world that when good quality palliative care is administered, people actually exceed their life expectation. Because it's not that the disease is getting cured or treated, but something in them restores that will to live. And a lot of people who are close to the end of their lives, who are in so much pain, would rather not. I mean, they don't want to live like that. So let's be very clear about this reframing of hope and what palliative care can actually do. I can see the chat box is exploding, so I will just quickly check. All right. Okay, great. I like this chat box. We need to save it. Next. Okay, now palliative care, this is a very Western way of looking at it, but this is the sort of definition that we look at. It is the active holistic care of individuals across all ages with serious health-related suffering due to severe illness, and especially of those near the end of life. It aims to improve the quality of life of patients, their families, and their caregivers. Okay, and if you look at the diagram, you're seeing that palliative care can start right from diagnosis and comes into sharper focus towards the end. Okay, so it's not that it only comes, it's not like this is a, I'm sorry, there's a chicken that's like going crazy behind me. I hope you can't hear it, but if I really hope you can't. Okay, anyway, so it's not like it's a block that comes to a stop here and then a next chunk starts. It's a gradual intersection that happens, and it increasingly becomes more important towards death. Okay, and there are a couple of really important words here: active, holistic, all ages with serious health-related suffering. And it comes into sharper focus near end of life, and improving the quality of life of not just the patient, but also the families and caregivers. That's a very important thing. Palliative care looks at the entire family as a unit of care, not just the patient, because we are all so interdependent on our families and the communities and the fabric of society that we live in, that the illness of one person does have a ripple effect across everybody and vice versa. Okay, now this is another way of looking at it. You have a life-limiting illness, which sometimes becomes a terminal illness, and there is a situation of pre-active dying, and then there is actively dying. Now, those of you who are unfamiliar, actively dying is actually those last few hours, maybe a couple of days, where the system is shutting down. The body is, organs are shutting down, the breathing changes, you have something called a death rattle and so on and so forth. So that's the active dying phase. But there is a phase where the person becomes more and more withdrawn, and different symptoms might emerge at this point. So this is another way of looking at it. Okay, but if you really look at it in that sense, it's not just empty sort of rings. If you look at it through a palliative care approach, each of these circles that we're looking at, there are several things that we can do. Okay, symptom management, maximizing quality of life, palliative chemotherapy, radiotherapy, surgery, maximizing community support. So this idea, when someone says, there is nothing else we can do, there is nothing more we can do, now go to a palliative care team. Please understand that there is all of this still left to do. Okay, there is never nothing we can't do. So when a person has a life-limiting, life-threatening diagnosis, prognosis, this is also a great time to have these conversations with them. These are not easy conversations, but they can be had. As they approach end-of-life care, we're stepping up the symptom management. We're bringing in perhaps spiritual support at this time for the family as well as for the patient. And we're increasing psychosocial support for the family. And of course, ongoing medical treatments as appropriate. And finally, in terminal care, we're doing away with all the excessive stuff. We're just talking about what is absolutely essential to the family at the time. We will be talking about this in more detail when we do our grief and bereavement sessions later down the series. Okay, this is a graphic I'm very proud of because we came up with it. And a lot of the time people think that palliative care is just end-of-life care, but in reality, palliative care is this absolutely blooming garden where you have all kinds of things coming together. You have community, and community for us is really the cornerstone of where it all stems from, literally, because without community support, there's not a lot we can do. And the Kerala model also follows that very, very closely. And empathetic communication, we've made it the sun and the clouds because it is overarching over everything. And you have different aspects of restoring dignity and so on and so forth. So anyway, we'll be sharing the slide deck with you so you can take a closer look at this slide then. Now, here's an interesting concept, total pain. Okay. Would someone like to read this out for me? Any volunteers? Jayapakya?
Yeah, ma'am, I can. When a
Please
patient reports his or her subjective pain on the pain scale, it is important to remember that the physical pain reported by a patient is compounded by his or her current life circumstances.
Okay, so I'm going to give people a few seconds to read that properly for themselves. Now, what does this mean? What does this mean? That your physical pain, your experience of pain is compounded by your life circumstances. Shall we take a second to do a thought experiment and also use this time to turn on some cameras, just so that I know people haven't gone off to sleep or make a cup of tea. Great. Okay. So how about this? It's a Sunday afternoon. All your chores are done for the day. You have nothing else to do. And you feel this little bit of a headache building up. Okay. It's a regular kind of headache. I'm not talking about the migraine level kind of headache. This is just a headache. Now, what would you typically do about a headache like this on a Sunday? You're probably at home. Hopefully you can be at home. You have people around you who can look after you. Somebody is going to make you a cup of tea or warm water or soup or something. Somebody's going to take a nap, basically lie down, rest, and maybe you'll be okay in a couple of hours. What does that, on a scale of 1 to 10, 10 being the highest unbearable pain, 1 being minimal pain, where would you rate that headache? I love that. Get a head massage. That would be great, even anytime. Okay, so 1 to 10, where would you rate that headache that I just described to you? I love that someone said Amrutanjan and go to sleep. I would also do that. Okay. 7. Okay, fine. 10 being the highest. All right. Let's try this now. Okay. Same headache, but Monday morning, you're late for work. One of your children has developed a bad stomach and has decided not to go to school. You have a flat tire on your way to work. You just realized that you had a deadline on some assignment that you've not submitted, and your boss is calling you. You're already 45 minutes late. Your boss is calling you and saying, where are you? The meeting has started a long time ago. Your wife calls you or your husband calls you and said that child has now started throwing up and vomiting. Same headache. Pain scale, 1 to 10. Apart from some superheroes who can handle that level of pain.
Like, ma'am, there is one.
I was like, what pain relief are you on? I want that. Okay, so this is total pain, guys. This is total pain. The fact that your life circumstances will dictate the level of your physical suffering, even if that physical suffering is the same. On 2 different days, it can feel entirely different. Now, what I actually shared with you was a very trivial example. Can you imagine what it's like for somebody who's been diagnosed with advanced cancer, who's going through that pain, who doesn't have the money to pay for their treatment, who has to pull their child out of school, their caregiver has to quit their job, come back, somebody else has to move house. Can you imagine what their pain is? And what it would seem like on a pain scale of 1 to 10. So if I have to help that patient bring their pain scale level down from a 10 on 10 to a 3 on 10 even, I can't be just looking at their physical pain management. I have to look at everything else that is being affected by this illness in their family. So that is total pain. And that is what palliative care is trying to address. Okay, so I'm going to let you take a minute to sit with that thought and tell me what came up for you just now. We're not going to spend a lot of time on this, but if there is someone who has something to share that they'd like to share at this point, please feel free to unmute or to use the chat box. And it's okay if you don't have anything to share either, no pressure. Vishnu, are you trying to say something? No, okay. All right. Okay, so anyway, let's bear in mind what total pain is and what it looks like and what it may feel like for different people. Now, illness-related suffering is much more than physical distress. Like I just said, there is a physical component, there's a psychological component, socioeconomic and spiritual. And what we need to do is try and look at all these different boxes for the patient and their family and see what part of their suffering can we take away from it. I'm not going to show you this video right now because if we have time in the end, I'll show it to you. So I told you now what is palliative care. Now the question is why palliative care? And I think you've already got a sense of that. Now, palliative care in the way that we sort of deliver it and experience it here in Pallium India and in Kerala is like this. So the usual model of healthcare is this. You have the person, you have the healthcare system. And very often they are apart from one another, and as they should be. People only go into a hospital when they're feeling very sick. So already when they're going to a hospital, they're not feeling their best. They're certainly not feeling very good about life. And for most people, this is probably the worst they've ever felt. Okay. And I have this lovely friend, Dr. Roop Gursahani, who at some point, I think you will have a session with on end of life care. He talks about how sometimes modern day healthcare institutions are like fortresses where the rich can't get in and the poor can't get in and the rich can't get out. So there's a sort of a barrier between people and the healthcare services oftentimes. What we look at in the Kerala palliative care model is to what we call social capital. That is the people who make the communities. And they become the bridge for this gap that exists between the micro and the macro. And how do we do this? Oh, 1 second. Before I go into this, I can already see that we're at 45 minutes. And I can see some people moving around a bit. So shall we, Rajalakshmi, with your permission, take 2 minutes and just get everybody to stretch a little bit?
Yes, ma'am. Yes, we can take a 2-minute quick break in between.
All right. So a good way to do this is, I would say, those of you who want to go on a bio break, please do. Please get that cup of tea that some of you were really pining for earlier. And please be back in 2 minutes. We will start at 3:48. For those of you who are still sitting in front of your screens, great time to try and drop your shoulders away from your neck. A lot of us hold a lot of tension in our jaws, so please unclench your jaw. You might not even be aware of the fact that you're doing it. And it's a great time to also just sort of flex your fingers, get some blood circulation going, and we will reconvene in a minute from now. Let's go back to what we were talking about. We're talking about how this kind of community-based palliative care is delivered. So what you're seeing in this photograph is a community link center. And this is I would say this is the foundation block of the Pallium India palliative care service delivery model, where people from the villages, from the panchayats, from the communities, they come to us and for volunteer training. And what does this volunteer training mean? It means that people from the community are trained in identifying when somebody might benefit from palliative care services. Now, it could be someone who is elderly and living alone. It could be somebody who had a bike accident and has a spinal cord trauma and is now paraplegic or hemiplegic. It could be a single mother living alone with a child with a congenital anomaly because she's been abandoned by the family. It could be any number of people. Now, these volunteers are trained to be sensitized to this, identify the people who might benefit from it. And we have these link centers where we have home care teams that go out in, I think, 14 different directions every week, every day of the week, except Fridays and Sundays. And only Fridays. And they go and visit people in their homes. Remember, Astana said, meeting people where they are, when they need it. That's the premise of home care. Now, the link center is usually a public place in that panchayat or that village. Like in this case, it's a primary school that belongs to the village, and where the home care team goes, and people from around the village who need palliative care, caregivers, they come, patients come. Now, the ones who don't show up here, the ones who probably need the most amount of help because they can't make it here. So once everybody is seen here, medicines are dispensed, etc., the team then goes to the houses of people who could not make it to the clinic, but who've been registered. Now, volunteer's job here, if he has recognized that someone in his village needs palliative care, will register the person's name in this link center register, indicating to the healthcare team, that home care team, that they need to go to this person's house. So in that sense, they become our eyes and ears on the ground. And very often you'll find that the volunteer will then accompany the multidisciplinary team to the house. A lot of the times, these places are not very motorable. The gradients are in a way that cars cannot go. And sometimes these are very rural or geographically challenging areas to get to. Typically, we see people from all socioeconomic backgrounds. We go to wherever it is that where they're living. Sorry, Raju, there's some background noise. Okay. And one of the benefits of actually visiting people in their homes is to understand the condition in which they live. what is possible for them, what is not possible for them, who are the people in their community or in their families who can actually help. Now, very often what will happen is, now let me give you an example. Person goes to the hospital, everything is looked at as per the test results, investigations, etc. Now, going purely by that, medicines are prescribed and a certain sort of intervention might be prescribed, okay? And they say, okay, this person has to be given medicine 3 times a day, once before food, twice after food. Great, go home. Now, the person may not have a full-time caregiver at home from the family because they're living with one other person who is now working somewhere else. Who's going to give them that medicine and that food 3 times a day? Okay. Who is the nearest person there? Is there a neighbor? We don't know. Simple things like in a lot of places, water might be some ways off. Just getting access to basic stuff like food, water, shelter might be difficult. People might have roofs that are leaking. And that's the main concern of the family because in the monsoon, that's what's worrying them. The medicine itself might cost, say, 300 rupees a strip of medicine, which might be that one breadwinner's earnings for the week, which they're not now getting because they're staying home to look after somebody. Okay, you might need, okay, hygiene is really important. There's a fungating wound that is open and the wound dressing needs to be done, but it has to happen under hygienic conditions. Hygienic conditions may not be possible. The nearest toilet might be a walk away. So there are all of these different conditions that really then get us to think as a medical team, what am I prescribing? And does it align or is it cohesive with what they can actually do for their families? So it just adds that extra layer of understanding what is it that I'm prescribing and is it possible for this family to follow this prescription? Okay, so it's as much a learning experience for us as it is for people who as much as it is for us to go and help someone who we're visiting. Now, here's a story I want to tell you. This is a young man who, when we went to visit him when I was there, he must have been 21. He had had a horrific road accident 3 years prior to this. Okay. And he went to the hospital, he had his surgeries, etc. There was some amount of head injury, and a lot of it was, had affected his spine and his body to a large extent. Now, what had happened is that the doctors then said, fine, he can be discharged, he can be taken care of at home. There's nothing major now, except that he has to come for physiotherapy once a week, and then we can take care of him. So here's the thing. This guy, he only had one parent. Okay, his mother. She had to work every day to make enough money to pay for his medicine and other treatment costs. So she couldn't be with him. Their house was on top of a hill after 2 hills, about 1.5 kilometers away from the main road. For this boy, and he's a big guy, okay, for this guy to be taken to the hospital once a week on a weekday, 4 grown men in the village had to take half a day off to put him on a khatia or some sort of some sort of thing that they could carry him on, carry him 1.5 kilometers to the main road where there was no bus stop. And she had to organize an auto which had to take them to the hospital in the city, wait there for 2-3 hours till the physiotherapy was over and come back. And that cost her more than her week's wages. So tell me, how much physiotherapy do you think this guy got? How much physiotherapy do you think he got? He got none, is to tell you the honest truth. I mean, they tried it once, but it was just not feasible. So 3 years down the line, this boy hadn't gone for any physiotherapy. He had deteriorated. A lot of his muscles had atrophied. And he got depressed also. Completely reversible condition. So then that's when some volunteer in his village basically said that, yeah, he qualifies for palliative care. So his name was put in the register, and then we went to see him. And what was done was then the team went and saw him every week. He got his physio. And also they did what we call reverse innovation. I mean, we didn't call it, the Americans call it reverse innovation, where we put in parallel bars. He couldn't go to the physiotherapy center, so we set up a makeshift physiotherapy center for him at home. And after a while, he was able to do these parallel bars on his own. And I think, if I'm not mistaken, I'm quite happy to report that this boy is now mobile. He's moving around better, and he's come out of his shell, and he's re-engaging with life. His mother, I have pictures of her mother, which I haven't put on the slide, but there are pictures of her smiling as she helps us do this. It took us 3 years to reach him, but we got to him. It makes us stop, and I hope it makes us stop and think, you know, when we say that this is what is going to help this person, we need to also look into what the family can actually realistically do, to what extent. Because what happens then is you find that the family will come back, and then the doctor will scold them and say, "Arey, why did you let it get so bad? I told you he had to come for physiotherapy once a week. You couldn't do even that much." And over and above the utter helplessness that the family has and the amount of pain they have to go through in order to even just make this happen, we are adding one more layer of guilt into the experience. Okay. Now, we also recognize that it's great to be able to give out medication and interventions for free, but what's the point if the family is below the poverty line? And they are below the poverty line because of catastrophic out-of-pocket healthcare expenses, and they can't even afford food. Over 100 families in our care today get, in addition to medicine and home visits, they get monthly food rations, because otherwise they would starve. So let me just expand this for you a little bit and say that from our side, providing food rations is also part of palliative care. Very often, this is the kind of terrain that is being traversed in order to get to the patients, because something can be available but not accessible. But we try and bridge that divide a little bit. And so this is just a typical day. And for those of you who know Kerala, this is on a day when it's not raining, and that's not very many days in Kerala. It is really one of the, there is a spiritual dimension to care. And very often we think of spirituality, we think of spirituality as a religious thing. And what I really want to say is that spiritual care in the context of what we're talking about today is not, it includes our faith, it includes our belief in God and a higher power, but it also includes other things like what brings us meaning, what gives us purpose, what gives us hope, and what keeps us connected to the people around us. So meaning, purpose, hope, connection, these are all part of a spiritual experience. And how do I make sure that the people I'm caring for have that sense of spiritual care? How do I get them to feel like their lives are meaningful, there's a purpose? Now, a lot of it has to do with our sense of autonomy and who we are as people. If I were to ask any of you today, who are you? I just call out some random names and say, introduce yourself to us and tell us who you are. 9 out of 10 times, I feel people will start by saying, what? What are you going to tell me about yourself that you think I need to know? You can use the chat box. And this question is to everybody here. Tell me what I need to know about you. May as well put something down in the chat box, because we're going to be together for another 15 sessions. So what is it that you want me to know about you? Everyone's asking me questions back. No, tell me, actually tell me about you. Please write about yourself. Write about yourself. Annapurna, tell me your profession and passion. And Ashwati, tell me why you are interested in palliative care. Why? Sibin is asking why. I'm asking because so that you can tell me what it is about you that I need to know. beneficiary. You can unmute and speak up if you like.
Jobby, you wish to share something? Ashwati?
Yes, ma'am. Yes, ma'am.
Yes, please go ahead.
Ma'am, actually, I studied in a government medical college. I saw a lot of cases like this. They are having this financial crisis and they are not getting adequate treatment and all. At that time, I was interested in this thing, but I don't know. I didn't know how to raise these types of people. But later, I came to know this about this palliative care and all. And by that time, my father got dementia and he's bedridden for some time. And these palliative care people, this group came to my home. And after that, I got more interest. I got interested in this thing, and I joined this course. And after that, I worked with this palliative care team for some time. I think, ma'am, actually, this is what to tell, ma'am. Actually, this is a very complex thing. The patients, the caregiver burden. This is very, very deep, ma'am. It's not we can't express it in a single word or, single sentence. And not only this caregiver burden, they are having, I don't know what to tell, financial issues are there. They're having the psychological, they themselves, these caregivers are themselves suffering a lot. Majority of these people having nobody in their home, they might be their single breadwinner. This is very difficult for them to, at least by being in this profession, I think it is a great thing for us to help them, at least for a little, I cannot able to express my feelings completely.
You've expressed yourself quite well, Ashwati. Thank you. And I appreciate you speaking up and highlighting also the caregiver burden aspect, which I thoroughly agree with. What I'm hearing and reading in all of your responses is a sense of purpose in wanting to be of service to other people, a sense of, bringing care and service into the world. I can see that there are many, a lot of it is that. A lot of you are here to be in service of others. Now, what if tomorrow you get diagnosed with a severe illness and you have to stop working? Where will you get your sense of purpose and meaning from then? I'm sorry, it's not an easy question to answer, but what I'm trying to demonstrate to you is a lot of who we are and our sense of ourselves is tied with what we can do for other people and what our contribution in the world is. Whatever it might be, it could be medicine, it could be art, it could be music, it could be just creating something of joy or just doing something even for yourself. It doesn't even have to be for someone else. It's just creating beautiful things. Now, when illness strikes, that's one of the biggest things taken away from us. Our ability to do what we so far have defined ourselves by. A lot of the times it's by our chosen profession or by what we are in our family, our roles. You're a father, you're a mother, you're a brother, you're a sister, you're a caregiver, you're, so many things. And if you're not able to do that, then what? How many of us would be happy to just be recipients of care from a healthcare service? And that's it, and not have anything to give back in return to our families, to our communities. One of the things we try and do in palliative care is restore that sense of dignity and autonomy that comes from having a sense of purpose. And that can be done by sitting with people and saying, what would you like to do? Now that, like some of you said, to readapt, you have to adapt and, readapt to your current scenario. What if your current scenario is debilitation, physical debilitation? What you're going to do then? So it's very important for us to sit with that person, understand what is it that gives them a sense of meaning and purpose, and see how they can come back to being contributing members of society. I can see a lot of very deeply profound things being shared. I'm going to take some time towards the end of the session to go back to the chat box. So these are just two small pictures, but for a lot of people, it's to be able to contribute and earn a living for their families. This gentleman here was, he had a spinal cord trauma that left him paraplegic from the waist down. He was the primary breadwinner up until that point. But when that role was taken away from him, when his wife had to go to work and when his children had to drop out of school and so on, it left him feeling very depressed. And there's a lot of existential and spiritual distress. One of the things we found that he could do is get in the business of umbrella making. And luckily for us in Kerala, we always need umbrellas. So this is a way in which he now contributes to the earnings of the family. He has a sense of purpose when he wakes up in life, in the day, in the morning, and he re-engages with life. We have women who have been abandoned by their families because they have given birth to children with congenital anomalies. There are superstitions around it. They usually blame the woman. So you have a young woman with no means to support herself, sitting at home with a highly dependent child. Well, a little bit of cottage industry. She knows how to sew, so she can be with the child at the same time, earn some money. So I'm here to tell you that this is also part of palliative care. Although this might be expanding the definition quite a bit, what you can also do amongst yourselves is hook up with organizations that are already providing this kind of support in the communities and bring them into the field of, into the scope of your work. Children, often invisible to the larger healthcare system. It's important that their education and their sense of play and their sense of being a child is still held together. We will talk about children more in another section. Like I've said a couple of times already, one of the biggest casualties in this whole journey of being diagnosed with a serious illness and finding treatment, etc., is that children's education is impacted. A lot of the times, for a lot of families, they have to pull their children out of school, take that education money, put it into tuition, into treatment. And what really that does is it takes away the future of the child. And so you're seeing the disease of one person in one generation impact the actual future plans and opportunities of the next generation. And that sort of financial toxicity going into multi-generational loss. So one of the things we try to do is to not let that happen. And how do we do that? By supporting the education needs of children whose parents or whose family members have been either struck down by illness or who have been impoverished by illness. And I would say we have, I think, supported so far up close to 400 plus children in their education needs. And I'm very happy to tell you that some of them have chosen medicine as their professions and are probably going to become doctors and nurses and sort of paying it forward in that sense. And of course, especially we pay attention to the invisible patients. We'll be talking about that a little bit. Elderly people living alone, women, children, and so on and so forth. So one of the, very quickly, now I've told you the why of palliative care, in a community-based model and the importance of community-based palliative care. And part of the work that we all do, every single one of us, even if some of you are today encountering palliative care for the first time, raising awareness is our number one responsibility. We have to, because less than 4% of India gets access to palliative care. And that is with all of us palliative care people working at full stretch. So there's one palliative care provider for 1 million Indians. Currently, that's the ratio. We need to change this because the benefits of palliative care, as you can see, are immense. Now, there's this interesting, I'm just going to touch upon one thing. This is about access to medicines. That's primarily my portfolio at work now. There's a very interesting saying that says, if you're not at the table, you're probably on the menu. If you don't have a seat at the table, you're probably on the menu. What does this mean? If you are not at decision-making places, people are making decisions about you that are not in your best interest. Okay, so that's why advocacy becomes really important. We cannot be content with just working in our units. We have to mobilize and get together and talk about our collective needs, because global policies do not reflect the needs of people from low and middle income countries. Global policies are designed for high income countries. So all of us need to really collectively come together and say, you know what, these are the needs of my patients, of my communities that I serve. And then let's take all of that and get a seat at that table. so that the decisions that are being made about us are actually for our benefit. And this is a map. You're going to look at this map and say, what on earth is this map? This map reflects access to opioids for pain relief globally in terms of the needs met, proportion of needs met. So we know about the crises in North America. That's a different crisis. We won't talk about it right now. Western Europe has struck a balance. They have more morphine and more opioids than they need really. Australia has it. But look at all these countries in the middle. We have nothing. And a lot of these countries that have almost disappeared off the map are countries where the raw material for opioids comes from. So this is a map of injustice, and it's a map of inequity. And a lot of us are working to make this okay. So if you're more interested in this conversation, I'm very happy to have it with you. 75% of the world remains without access to proper pain relief treatment. Asia's morphine per capita consumption is 36 times less than the global average. Means there are that many people in India. 1985, the Narcotic Drugs and Psychotropic Substances Act, NDPS, made famous, I think, more recently by Shah Rukh Khan's son, Aryan Khan. It tells us who has access to what narcotics and pain medicines and so on, in addition to all the restrictive control laws. And when this came in 1985, the morphine consumption of India fell by 1997 by 97%, from 716 kgs consumed in the country to just 18 kgs. What this means is that the pain burden in our country shot up by that much. So one of the biggest barriers to pain relief in our country is our law. And we are also working quite persistently to make sure that the law is amended in ways that it actually benefits people in need. And we were actually successful to a certain extent in 2014. We'll talk about that later. So globally, people talk about, the war on drugs and things like that. But please remember that there's another side to the war on drugs. The principle of balance, all the countries came together and signed a treaty that said many things about control of drugs and trafficking and so on. But it also said that we have to prevent, not the abuse of opioids, it said we have to prevent illicit diversion, but we also have to make sure that these are available for medical and scientific purposes. And in our country, it means for those in pain. But the balance, unfortunately, is very skewed. So we have the international laws of criminal justice that says, let's prevent the diversion and illicit use of things like opioids. And then we have international laws of human rights says, no, you have to make it available for people in pain. And the balance of public health is the green, is the purple bar. Unfortunately, that's not how it is. So now, very quickly, I'm going to end by saying that this was one of our patients. He spent 3 weeks in this position because he was in so much pain. And he couldn't even sit up. He was given 3 rupees worth of immediate release oral morphine. And for the first time in 3 weeks, he was able to sit up and have a cup of tea. So that cup of tea that all of us were really, anticipating at the beginning of this session, he hadn't had a cup of tea in 3 weeks because he was in so much pain. And that one immediate release oral morphine tablet was able to give it to him. So it can come at an affordable cost if only all of us become aware of it. And I'll just stop, by reiterating the point that a good health system delivers quality services to people where they are when they need them. I want to just play, before I open the floor to questions, I would like to just play one video for you, which has been one of my favorite videos. To me, it really captures the essence of palliative care. It was made by the African Palliative Care Association. And let me just cue it for you. Okay. Sinya and Raju, I'm going to look at you to see if my sound is coming through, yeah? So in a lot of ways, I think that that video captures everything that I've tried to ramble on about for the last 1.5 hours. So that brings us to the conclusion of our introduction to palliative care for you. And we have 10 minutes. So if anybody has any questions, I'm happy to take it. And I just want to take a quick look at the chat box. I love the fact that so many of you actually answered those questions, and I'd love to read through them more carefully.
Thank you, ma'am, for that wonderful session. So, ma'am, we had a question in between. How different is palliative care from hospice?
Okay. So hospice is a very, well, the hospice movement started in St. Christopher's. Cecily Saunders, the one who is accredited with starting the modern palliative care and hospice movement. Hospice is a place where you take, and also it's not just a place, but it's also end of life care. Hospice is end of life care. And a hospice could be like the place, like Karunashraya Hospice, or the hospice, my mother is in hospice or needs hospice, means she needs end of life care. So hospice is specifically end of life care. It could be for a few months, it could be for a few weeks, it could be for a few days, but it is with the full understanding that this person is dying, and the dying process has somewhat begun. So that's hospice. Palliative care, like we said, is anytime. It can be started at any point of the illness trajectory. People live for years and years and years with palliative care, especially with good palliative care. That young man for whom we put in parallel bars, I hope he lives with us a very long time. In fact, there are a lot of people in our rehabilitation services who have transitioned from pediatric to adult care and have been with us over 15 years. So I hope I've answered that question.
Anup Yadav, you have raised your hand. Anything to ask, sir? You're muted, sir. Can you unmute from your end and speak?
So the most of the discussion with the palliative, people talk about it's people have financial issues with the palliative. But as I am working with palliative, the only thing which we are lacking is the information, because everything is very economical by the government. Morphine is very cheap. Even with the 1 day of wages, they can continue the chemo for palliative for 1 month. The only thing is lacking, they don't know what to do. So what is happening when I started it? Every time the cancer patient is not responding to treatment, so we say, seva karo, go take home, seva karo. But family have no clue what need to be done. So what they do, they take the patient home, and the patient will be suffering, struggling with pain and everything. And one day he collapsed. That time they take the patient back to the hospital. And as per the hospital protocol, we do all the workup, do 1 day admission, do so many testing. Then the bill will be around 1 lakh. And the next day morning, we go and tell them nothing can be done. Go back, take them home. So it's just like they are not properly informed, they are not properly educated. Otherwise, the palliative care setups and even the palliative care for any patient is very economical. And I think anybody can afford it. But the idea here is the lack of, like, people, when you get a call from the patient, I'm getting a pain, I say, we can start a morphine. So you say, I'm already taking a morphine, but the dose is completely wrong. Yep. Most of the time, the doctors are writing it not properly, not guiding the patient how it need to be taken. So what patient think, yeah, I have tried the morphine, it's not working. But the problem was he's not taking it properly. So these are the problems. I think it's more like information. If the platform like you, if they educate well with the doctors and the nurses, these problems can be solved easily.
Anup, thank you very much for that. I completely agree with you. And I would say that, yes, information is the #1 missing piece here. Information, not just in terms of, that these services are available, they're affordable, they can be done within a certain cost, or the fact that, and the information is not just lacking in terms of going to the patient and the family, the information is lacking in the healthcare system. The referrals are not happening on time. Or they don't know, like you said very clearly, morphine de rahe, but 10 mg morphine for a full day is not going to cut it. So you're absolutely right. Information, training, communication, these are essential aspects that are missing. And once those things fall into place, I think a lot of the other things that we discussed today as barriers can also come into play. And I would say information is also key in terms of advocacy, right?
Yeah.
So yeah, information is absolutely key here. Thank you for that insight. And I think I'll be leaning on you quite a bit in the coming weeks to also, add your perspective to what it is that what we're talking about here. We will be doing special sessions on communication and so on. How much of hospice care will be touched upon in this course? I would say that you can't separate hospice and palliative care completely. Elements of hospice exist in palliative care, and hospice is entirely palliative care. So we will be touching upon end-of-life care. We will be talking about grief and bereavement. We will be talking about advanced care planning. Those are the kind of things we will be talking about. So we will be touching upon those aspects, but that is not specifically only hospice. That applies to right through the trajectory. Who is going to provide for all the costs? Jayanta, I'm not sure what that question. Can you try and expand on that question for me, please? Jayanta Ghosh.
Yes, Jayanta, can you speak up?
Ma'am, is there anything you need to know?
No, I guess I'm trying to understand your question better. Who is going to provide for all the costs?
Yeah, ma'am, as I was following the whole system that was running in palliative care, so it seemed that a lot of people are involved in it. So how are these people being provided for? How are these people being supported in, is it a part of their profession, or is it simply a philanthropic service? I'm not sure about that. So the question came up.
Good question. So there are different models of service provision. Ours is an NGO, so we are funded by various organizations and institutions, and also a large part of our running cost comes from individual donations of people who we have taken care of. So our services are free of cost, but a lot of the times, because people receive good qualities palliative care, especially at such an intense time, a lot of people would like to come back and become individual donors to the cause. So that's one way of doing it. However, there is now within, for example, even the larger healthcare system, like under the Ayushman Bharat scheme, there is also under. Is that someone wanting to say something? Sorry.
No, ma'am, you can continue.
So there is insurance packages, but at the moment, insurance for palliative care is only for cancer patients. We're trying to work on that. Okay, so there are different models. Of course, now you have private hospitals that have come up with palliative care teams and departments as well. The medical college hospitals have palliative care teams. So a lot of them are absorbed into the larger system. So in our case, we're all working 6 days a week, but it is funded, but there are, of course, a huge number of volunteers who work with us. So the core team of about 100 people, we are salaried people, we are part and parcel of the team, but we rely a lot on our volunteers to also support us in our community work. So I hope that answers that question. Soja's question is why some people think if a palliative care approach is taken that a patient will die soon. It's precisely because of the myths around palliative care. And I would say a lot of the, like Anup was saying, the medical fraternity itself has to be educated about palliative care. So a lot of the times those referrals are not made, or people believe that once you're going into palliative care, that means you're coming to the end of your life. And that is something that we need to change. We have a long way to go. So I just want to take 1 second, please, to I think we'll close the questions for now, but I want to just say thank you very much to Abhilash and a few others who have really, shared from their heart in the chat box. I feel like this is, in addition to being an educational space, I hope that over the next few weeks, we grow into a sort of community of people who share our stories also with one another. because there's as much to learn from that as there is to learn from just the data and the statistics that we will be sharing with you in educational format. So I really want to thank people here who've had the courage to share their personal stories. I would request that the rest of the group receives the story with a sense of respect and also, of course, confidentiality. People are sharing important parts of their stories with us. Let's be respectful towards that so that more people are encouraged to share. And definitely we'll have case-based discussions later. So I encourage you to please, listen to Sinya and Raju and submit some cases. So thank you very much. I'm really looking forward to getting to know all of you better. And for those of you who tend to be quieter in sessions like these, I'm going to ask you to also speak up using the chat box. Thank you, Raju and Sinya. I'll stop with this.
Thank you so much for that wonderful presentation, ma'am. I think by now you have got a clear idea what palliative care is all about. So as continuation of this, we can meet up on next Friday with a topic on interdisciplinary team taken by Dr. Sangamitra. Till then, thank you all. Bye.
Thank you. Take care.